Janelle Hannon, and I am the moderator for this session. Before I go on to introduce our speakers and we start rolling on things, just a few reminders. You can increase the size of the slide presentation by right-clicking on the presentation image and selecting Picture-in-Picture and resizing the pop-out window. During the presentation, you're also welcome to put your questions and comments in the room chat, which you can open by clicking on the chat icon at the top of the screen and selecting Current Room. And at the end of the presentation, you'll be able to ask any questions using your microphone by raising your hand. And if there's no questions about that, I'll go on to introduce our speakers for this session. So first, we have Heather Prescott, who is a primary care nurse practitioner practicing in mobile addictions and street medicine with Grey Bruce Health Services, Owen Sound, and serves as a clinical lead for supportive outreach services, also known as SOS. She graduated with a Bachelor's of Science in Nursing from Toronto Metropolitan University and a Master's NP from McMaster University. She spent the majority of her 10+ years experience as an NP serving unrostered and marginalized communities with a focus on mental health, addiction, gender-affirming care, and chronic disease management. Next, we have Teresa Tibbo, who is one of the primary care paramedics on the Grey Bruce Supportive Outreach Services team. She started her work in healthcare as a registered practical nurse in long-term care with a focus on quality improvement and has since moved into emergency nursing. Her passion has always been emergency care, so she returned to school a few years ago for paramedic training and has been working with Grey County paramedics ever since. She's enjoyed being a volunteer firefighter for 10 years and plans to be for at least 10 more. She has settled into the SOS role over the last year and enjoys working with a team of like-minded individuals. She is passionate about breaking stigma around mental health and addictions and helping her clients access the care they deserve. And lastly, we have Robyn Nocilla, who is a primary care nurse practitioner with over 10 years experience. She currently works as a full-time NP for addiction treatment services and the Grey Bruce Health Services RAM, providing addiction medicine and primary care services in rural and Indigenous communities. She has her Honors Bachelor's of Science of Nursing from York University, Honors Master's of Science and NP Certificate in Primary Care from McMaster University, and Honors Diploma in Mental Health and Addictions from Mohawk College. Robyn presents for Indivier and Master Clinician, educating practitioners in addiction medicine across Canada. Robyn is a mother to a beautiful little girl, and when she has spare time, a sports enthusiast. And without further ado, I will leave you to start.
Thank you so much for the very warm welcome. We are so pleased to be here today to present our SOS model for Grey Bruce. I'd like to begin by mentioning that our team is greater than 3. There are 2 individuals, two teams not here today. Our team does have a pair of mental health and addictions counselors from our CMHA Grey Bruce, Mackenzie Gray and Carrie Borland, as well as our social navigator from the United Way, Sandra Holier. And always a pleasure to present with Teresa and Robyn today. I'd like to begin with a land acknowledgement. We acknowledge that we are presenting from the traditional territory of the Nawash and Saugeen Nations, a place that has long served as a site of meeting and exchange amongst many First Nations, including the Iroquois Confederacy, the Huron, Wendat, the Abenaki, and the Anishebek. We recognize and respect the Anishebek as the traditional custodians of the lands and water. We are committed to supporting the Anishebek and the Haudenosaunee peoples, among other First Nations, Inuit, Métis, and Indigenous peoples globally. We recognize the impact of colonialism on our First Nations people daily through our work. We also acknowledge that the people of color whose ancestors who came to this country against their will. We hope to make time, space, and resources available for truth and reconciliation. On our next slide, just wish to demonstrate our disclosures. As mentioned, Robyn has received Speakers Bureau honoraria as a master clinician with Indivier and PHI consultation. same honor presenter disclosure for Robyn. Myself and Teresa don't have any disclosures.
Okay, so I'm going to start into our objectives. Our aim today is to give a snapshot of supportive outreach services, or SOS, our mobile outreach team project structure and progress to date. Our overarching goal is to demonstrate the effectiveness of service delivery concept and its ability to be transferable to other regions to optimize the health access and equity of at-risk populations living with addictions. So I'll briefly just review our objectives there that you can see on the slide. We'll identify barriers to accessing addiction services in Grey Bruce, available services, service gaps, engaging marginalized communities, and additional rural barriers. We'll explore the development and evolution of the SOS mobile team, the history of implementation of SOS from 2021 to today, the expansion to SOS mobile in 2022 after receiving OHT funding for a 12-week pilot, strengthening community bonds of 20 plus partner agencies, and we'll share current data and evaluation. We'll distinguish between SOS mobile and other existing models of care, low barrier access to health and social needs, and the no wrong door approach. Interdisciplinary team with harm reduction model, substance use disorder and alcohol use disorder supports, including counseling, referrals, and addiction medicine on site and immediately available. The NP on the team who can delegate to the paramedic, and this provides the ability to utilize telemedicine, which expands our reach and capacity of the team for health interventions. So next slide. SOS meets people where they're at, both in physical location and in their journey, to provide person-centered health and wraparound mobile response to improve health outcomes and health equity of individuals experiencing barriers in accessing health and social services in Grey and Bruce counties. SOS was formed after the observed impact of a multi-organizational, multi-sectoral collaborative approach to addressing a COVID-19 outbreak in a rooming house in Southern Grey County in June of 2021. The outbreak highlighted the need to address health equity and health outcome gaps seen in individuals and groups that experience barriers in accessing health and social services. In addressing the outbreak, several community partners from both health and non-health sectors came together to organize a rapid and coordinated response. The focus was on client-centered care, which led to building connections with individuals that had not previously had the opportunity to access health and social supports due to equity, situational, or personal challenges. Many dedicated service providers and community volunteers supported upwards of 40 marginalized individuals with the Delta strain of COVID-19 while they remained in isolation in a 20-bed rooming house during one of the hottest Junes on record, with no AC, adequate cooking facilities, or cooling equipment. Food, drink, laundry, basic needs, and harm reduction supplies were brought in and out safely, meeting public health's IPAC standards. Trailers were set up for health, addictions, and social supports. Primary health care needs, management of withdrawal symptoms, cravings, and use were managed with minimal police involvement. Trust, rapport, and safety was established and fostered. Once the immediate need of the COVID-19 response was met approximately 4 weeks later, the clients didn't want the service engagement to end. Based on a community needs assessment, the first fixed site clinic was mobilized in a local church in Hanover and later expanded to Owen Sound on opposite Wednesday afternoons, offering access to multiple co-located health and social services, such as support for housing, employment, legal and mental health services, and immediate access to addictions medicine, access to food hampers, hot meals, hygiene and personal care supplies, harm reduction equipment, safer use supplies and education, primary medical care, and more. So some of the health partners you'll find at our fixed ID clinic, social service navigation, housing supports, Ontario Works, YMCA employment, court support, legal clinic, and the women's center, which is a domestic violence shelter. As the project evolved, the need for a mobile response to provide direct services to individuals was evaluated. A short-term proposal was developed to secure funding for a pilot mobile outreach project in January of 2022, and it was approved. The mobile team operates through the week to provide medical care, addiction support, crisis management, mental health care, COVID-19 response, wraparound social care, and supportive system navigation.
Our team can't reinforce enough the importance of interagency collaboration. Without partners in both the health and non-health sector, this project wouldn't have the financial or human resources to meet the complex needs of the individuals we serve. Examples on the slide include our formal relationships with CMHA Grey Bruce, Grey County Paramedic Services, Grey Bruce Health Services, now Bright Shores, United Way of Grey Bruce, and the Public Health Unit. Supporting partnerships in the counties of both Grey and Bruce, like social services, housing, paramedic services, and the cities of Owen Sound and Hanover allowed us space. Our police agencies gave us wide berth, allowing us to meet the needs of our clients. Nonprofit agencies like the Salvation Army and OSHARE provide food and basic needs. Grey County also acknowledges that it is located on the traditional territory of the Chippewas of Nawash, which comprises of 2 First Nations, the Chippewa of Saugeen and Nimiishing. The SOS program also regularly connects with Mawickanong Friendship Center, along with the Southwest Huronia Health Center in Sohac. We seek to respect and learn from our Indigenous neighbors, providing care and support upon invitation. The COVID-19 outbreak debrief provided us an opportunity to identify the barriers to access and begin to measure and monitor the impacts of health equity and health quality on our marginalized population. We identified that there was little to no income source, low employment, and a variety of Ontario Works and ODSP recipients. The individuals were transient with no fixed address. Sometimes 4 to 6 individuals were couch and floor surfing in each unit. These individuals frequently lacked identification and thus unable to access emergency shelter such as motels, their medication, and banking without. We identified that there was a high prevalence of mental illness, substance use, namely opiates, meth. This community was detached from the health system. They had minimal access to health and social supports due to equity, situational, and personal challenges, and a lack of transportation in our rural community. Complex community outbreaks among individuals experiencing homelessness or precariously housed individuals are not just limited to shelters and licensed settings. This outbreak debrief identified that a rapid response between organizations with person-centered care. They identified that there was a reduced number of emergency room visits, no opiate overdose, and no deaths. There was minimal police interaction, although available support was available when needed, and there was an improved uptake on addictions treatment options. COVID-19 highlights the importance of vulnerable population planning table with representations from various health and non-health sectors in the community with specific roles and responsibilities aiming to target health goals. Community partner involvement is crucial and integral in the response to support and leverage community action and reaching out to this population. It was agreed that establishing a community partnership with a mobile outreach and providing synchronized community care would help provide care to marginalized individuals that would not otherwise access these services. The goals included providing a coordinated community partnership with a mobile outreach component, providing a coordinated community care, helping reach individuals that would not otherwise access these services, address health equity, situational, personal challenges to access support, identify 2 fixed locations to develop a plan to provide these outreach services, and evolve to expand to services across the Grey County where needed.
A logic model was developed to show the relationship between resources, activities, and intended results. This was used as the foundation for developing an evaluation framework and key indicators for monitoring implementation and identifying areas for improvement. A health equity impact assessment was conducted and was used to prioritize opportunities for an improved health equity approach, including the collection of more detailed demographic data to better stratify clients based on equity indicators and understand the program's impact. So this next slide shows how it all comes together. Nurse practitioner, mental health counselor. I really can't say enough about our partnerships and how critical the collaboration has been for our success. The intended outcomes, the basic is the right type of care in the right place at the right time. And this includes everything you see there: medical care, addiction care, including same-day OAT starts, crisis management. We attend 911 responses when able, but our huge geographical area makes it difficult to make it to all the calls. 911 will dispatch us, and medics on the road can also call us directly. Comprehensive mental health care, COVID-19 response, wraparound social care, and supportive system navigation. Consistent care team has helped to build trust and rapport for sure. The SOS initiative is a collaborative project including many community partners operating through a multidisciplinary leadership table with decisions made through consensus building. The SOS initiative is divided into two project streams: SOS Fixed Sites and SOS Mobile. The fixed and mobile clinics are supported by an operations working group and a planning and evaluation working group. This diagram demonstrates the collective impact approach being used. The SOS collaboration is comprised of all stakeholders and partners involved in this SOS initiative.
This is an example of our SOS mobile model. You can see all of our roles here. The NP functions as the clinical team lead, with all members having a joint role in developing a patient-centered plan of care, and our leadership team acting as our backbone, funders, and for advocacy. Naturally, there's overlap in the roles, and this is mitigated with good communication and careful documentation. Our evaluation framework is on this next slide. You can see 4 pillars, the first being a community focus with community engagement, views and involvement of the community who utilize and are impacted by SOS. Secondly, you can see resources and services, fostering community engagement, collaboration, and trust. The number of resources used and the services delivered by SOS. Third, quality and performance, integration and responsiveness, and the integration of SOS into the healthcare and community service system, and capacity to continually transform our services in response to evolving needs, issues, and as evidence of changes. And finally, the determinants of health and equity. These are the health determinants and status, trends in disease, mortality, morbidity, and health behaviors. Pardon me. And finally, our logic model. I appreciate that this is difficult to see. This has been prepared by public health as you can see our inputs, strategies, activities, outputs, and short and long-term outcomes to support the goal of meeting people where they're at, to provide person-centered health and wraparound mobile response to improve health outcomes and health equity in individuals who experience barriers to accessing health and social services. We'll go into some of these particular items in the following slides.
Heather, there's been a question about the models being blurry and if they are able to get a copy or a screenshot later after the presentation.
Absolutely. I believe our slides in their entirety will be available.
And the other question is, while we're going and talking about SOS, just around how do you differ, or has there been concerns with regards to SOS as a safe supply?
You want me to answer those now? Yeah.
Just so that they understand that the name actually was peer driven.
That's right. That's right. So we do engage our the individuals who use our services for everything from what we deliver, where we deliver it, and what we call it. So yes, so individuals who access our services came up with the name of supportive outreach services, of which there are several in Ontario that provide a similar mobile model and are not Safe Supply. We are not offering Safe Supply at this time.
Okay, I'll carry on. So speaking of engaging our folks, this is an amazing example of it. On this slide here, I just wanted to draw your attention to the drawing on this slide. This is our SOS logo that was created by a very talented artist who is also a current SOS client. We worked with him and his family for months to stabilize him, treating medical conditions and providing OAT, and we're able to assist him with his admission to a residential treatment center. He is currently there and doing very well, and we expect to see him again in October. So I just wanted to give him a little plug there because it's amazing. So SOS Mobile is staffed by a team of 5 individuals, Monday to Thursday, 8:30 to 6:30. Beyond the fixed market clinics, the team attends pop-up clinics on a schedule, as well as drop-in centers, town libraries, and local church supportive of harm reduction practices, often together with partner agencies. The team travels up to a 100-kilometer radius to meet the rural demands of our community without reliable public transportation. We also deliver street outreach to local encampments, flop houses, and rooming houses where and when needed and invited. We provide home detox services and same-day addiction medication starts, especially for those individuals coming from incarceration or into the women's shelter from out of area without a prescription to continue treatment and with very low tolerance. Grey County Paramedic Services provides a designated, specially trained paramedic, means of transportation being a truck or an ambulance, staff room, and medical supplies required to provide primary care assessment and street medicine services, including symptom relief medications, antibiotics, wound care supplies, blood draw supplies, and more. Grey County is the fund holder for the program from Ontario Health West. Grey Bruce Health Services, now called Bright Shores, provides the mental health and addictions NP and the supplies necessary to provide mobile RAM services, including buprenorphine, XR, and urine drug screening kits, for example. CMHA Group Grey Bruce provides 2 designated mental health and addictions counselors with harm reduction training. United Way Bruce Grey provides a designated social navigator with additional qualities and qualifications in life skills training and ID clinic. They also provide the basic needs supplies that are required through fundraising, such as tents, sleeping bags, tarps, toilet paper, hygiene supplies, period products, and thousands of socks. Public Health Grey Bruce provides the harm reduction supplies, so our shorts and longs, meth, crack, cocaine kits, as well as naloxone kits, condoms, and point of care Hep C testing. And they also complete the evaluation of the program. The demand for primary care services in our region is very high due to lack of primary care providers, long ER department wait times, and very limited walk-in services. Grey County has also experienced an influx of retirees and a population boom during COVID-19. It's beyond the capacity of the SOS Mobile to meet the primary healthcare needs of all its residents in need and aims to work with the most vulnerable and marginalized, including, if you can go to the next slide, including these folks. Those who are unable to access primary care due to stigma or discrimination, mental health and or substance use, unsheltered or precariously housed, struggling with social determinants of health, Indigenous, LGBTQ+, women leaving domestic violence, and sex workers, those needing brief case management, system navigation, and referral back to existing health and social services. So a little bit about our partners. We recognize the impact of colonialism on our First Nations people daily through our work. We also acknowledge the people of color whose ancestors came to this country against their will. We hope to make time, space, and resources available for truth and reconciliation.
This is just a snapshot of that very, very large logic model I showed you with our short-term outcomes or our aims. You can see on this slide that our initial goals were to develop and provide a mobile outreach service, increase awareness of and referral to health and social services, to increase the awareness of harm reduction practices, increase the day-to-day service delivery and management of operations, that our clients are satisfied with the model of care and the direct services they receive, and also trusting and a positive interactions between clients and the service providers. And our longer term outcomes goals are increased integration of services across the healthcare system through interagency collaboration, decreasing the need for the utilization of urgent and acute care services, which would lead to cost savings to the health system, improved health and social outcomes in drug use behaviors, access to housing, employment, and income, reducing health inequities, and maintain support for the mobile outreach and sustained model. So that includes human health resources and finances.
As some folks might know, the opiate crisis really hit a peak during the COVID outbreak. In some communities, overdose deaths went up to 60%. The SOS team is a multidisciplinary, multi-agency team aimed to provide health, social, and wraparound services to folks in our community who might not otherwise have access or the ability to reach our traditional services. One of the things that makes our program really unique and points to the success is how we've been able to collaborate with so many agencies in our communities and build on their successes and resources. In the first 6 months of the initial pilot project of SOS, there was over 300 primary care visits, over 300 mental health harm reduction visits, over 1,200 unique clients, and over 3,000 units of basic care needs delivered to patients. We have a phone that we keep with us that we access phone messages and text. We travel where we're needed all over Grey Bruce. We bring with us whom is most appropriate, the best resources available. Very frequently, we're meeting folks in the streets, in their apartments, sometimes at other agencies, just trying to make folks feel comfortable in whatever environment works for them. Most notably, I'd say our patient outcomes are significantly improved. This is a really unique program. We're really truly meeting folks where they're at, providing them with choice and safety and trust, and also improving patient satisfaction.
Thank you so much, Sarah. I'm glad that worked so seamlessly. Awesome. Did not expect it to be that smooth. That's great. So that's an example of a video that was prepared for us by Grey Bruce Health Services, now Bright Shores, for a quality award, and is now used to aid in fundraising with the United Way. I just want to share some initial evaluations from our 12-week pilot project. Initially, activity tracking form was used to collect and record activities and referrals taking place within the SOS fixed sites or markets, as we've been calling them. An electronic survey database was developed thereafter to comprehensively gather SOS activities completed by the program partners. So outside of just the 5 of us, how many pizzas were delivered, how many socks were given out, how many referrals to CMHH services, for example. Results here are inclusive of services from February 2022 to March 2023.
So these next 2 slides speak to these results directly. So our total client interactions were 518, new clients were 247, and returning clients 271. I think that really speaks volumes that we've had that many returning clients. Number of services provided, 1,187, and number of referrals made were 176. Next slide shows the units of harm reduction supplies that we distributed, 639. Number of primary care visits provided, 157. Number of mental health and addictions brief counseling sessions, 260. COVID vaccinations, 11. Units of basic needs distributed, 226. So the program impact, we've had improved access and decreased barriers to health and social services, development of trust through safe, supportive, judgment-free services. I think that's really key in what we're doing is our clients really do understand that we don't judge, we're just there to help. Consistent access to multiple supports in one place, timely access to basic needs and medical supports, improved care and health outcomes. So the benefits of service provider collaboration: improve knowledge and understanding of services available, new and strengthened partnerships with shared goals, and a clear understanding of capabilities as well as limitations of the different partner organizations, increased ability to provide continuity of care, stronger working relationships, and improved understanding of the barriers that folks face.
Now, our more formal evaluation was completed. The utilization of that electronic survey database permitted for much greater detail demographic data to better stratify the indicators to understand the program's impact. A few of these data points will be shared on the following slides. And I appreciate that this might be blurry, but the slides will be available after. On slide 32 here, we see that the slide demonstrates the number of interactions month to month stratified by new or returning clients. You'll notice that there is a large spike in the month of May when that same rooming house that brought all of our partners together burned down. Without a shelter, individuals were supported in emergency shelter spaces in local motels across the region. These were funded by Grey and Bruce counties. Individuals required basic care needs like clothing, food, new identification, replacement of medication that may have been lost in the fire. A disaster response approach was carried out in the initial days to ensure wraparound supports were made accessible to the individuals. Again, you'll see a spike here in May, evident on some of these slides. Here you'll see a wide variety of services being offered by our team. You'll see counseling in pink, primary care in blue, support in green, addictions medicine in black, and education in brown. These are rarely delivered in isolation from each other. A burn dressing required from being on the nod around a campfire may quickly lead to a conversation about living rough and supports that might lead to more stable housing if our medical team is gentle and takes long enough. On the next slide, you can see specific to drug of choice. Our service users are pretty open with both our SOS harm reduction team from public health, as well as with our addiction care providers, such as myself. Drug of choice is largely methamphetamine in our community. You can see that in yellow. Opiates in turquoise, followed by marijuana light blue, fentanyl in purple, crack in brown. Alcohol is surprisingly poorly represented here. Heroin, cocaine, speed, and others are infrequently reported. Doesn't mean they don't exist, but doesn't always come up in conversation. Pass it on to Teresa now.
So the provision of basic needs such as food, personal items, clothing, and items like tents and sleeping bags are frequently the carrot to lead to engaging more meaningful conversations about health and social supports. These items are provided by nonprofit agencies and are not infinite in their quantity. There is certainly far more need than there is supply at this time. Fundraising and advocacy work are important roles taken on by many of our partner agencies. So referrals, it's no secret that across health and social sectors, there's often a bottlenecking phenomenon when referring folks to services who are in great need, but agencies have little capacity to bring on new clients in a timely, equitable way. With 2 mental health and addictions counselors on the team, they're able to provide brief case management, one-to-one counseling services, and referrals, advocacy, appointment, and court attendance with clients while they wait for longer-term outreach services and supports. It has helped immensely with follow-up and follow-through. On this slide, you can see the common referrals to addictions supports such as WMS, RAM, residential treatment, services out of our area, and more. Primary care, public health, and social services. So this slide is, again, pretty busy, but it's just an example of the drop-down menu options for our data survey for collecting all of our stats. It's a moving document, meaning that as new services become available, or they close, or when clients' needs change, such as with an increased number of pregnant clients being referred to public health's Healthy Baby program, we can add or remove data to keep this survey relevant and up to date. Overdose data. The SOS mobile team has a goal to achieve no more opiate overdose fatalities in Grey County. We know it's a big goal. Since the inception of the mobile team, overdose deaths in our region have drastically fallen by 60%. While we are proud to know our actions have contributed and have been recognized by public health, every death is as heartbreaking as the first, and we want to do all the work we can while fighting a toxic and unrelated drug supply and a host of socioeconomic and systemic challenges in our communities. Each day, we look at a sign in our staff room on the door that reads, reset, readjust, restart, refocus, as many times as you need to. Just don't quit. It helps us get through the difficult times. So now on to some stories of success, because this is the good stuff. A 39-year-old male was living under a bridge, estranged from his partner and 4 children, addicted to fentanyl. With SOS wraparound supports, he's now in remission for 8 months sober with buprenorphine XR and NA. He's housed in his own apartment, working full-time, and has access to his children. Having to face charges from his survival crimes during active use, the judge lowered his sentence to house arrest instead of jail time, given his miraculous turnaround and proof of ongoing supports with SOS. And Heather's going to tell us another success story.
The example I'm going to share is the baby in the image you can see here. A female, 27, was pregnant without prenatal care, heavy active IV fentanyl use with periods of methadone treatment, followed by long periods of withdrawal. With SOS support, antenatal lab work was completed, and with support and education over many, many weeks, she did reconnect to primary care and obstetrics at her local hospital. Despite her heavy substance use and irregular methadone dosing, she delivered a very healthy 8-pound baby girl who's now in kinship with a sister and brother-in-law, and she has a regular access, and so does dad in this image. I'm just going to come on to the next slide here. Using my mouse. There we go. Client experiences are certainly very important factor in completing any evaluation. We regularly monitor client experiences with anonymous client feedback box at our regular fixed site markets, as well as we formally evaluate client experiences with the OPOC mental health tool. This is a standardized way for gathering client feedback on the quality of care received across both community and hospital settings. This brings the client's voice forward as a source of evidence to support the program, our agencies, and the system quality improvement efforts. There's a few examples beside us here I'd like to read that we've received from service users. Thank you so very much. I appreciate it. You have no idea how much my life has been affected by all this. You've literally saved my life. I wish there was more things like this in other communities. I think it's an amazing program and hope it continues. 100% it saved my life. I see radical differences in the way you treat us like humans instead of low-life junkies. You guys are really superheroes. This little grassroots invention should be practiced everywhere.
So there are still some challenges that remain. Obviously, stigma and discrimination we're fighting every day. Lack of financial stability and long-term funding. The toxic, unregulated drug supply. Lack of drug testing, no safe consumption site, and no shelter in our nearby region. Health and human resource capacity funding for 4 days only, where we really need 7-day coverage, and lack of supportive transitional housing presently. But good news is there are 2 new facilities opening in Grey County in this fall. They will add 64 supportive beds for unsheltered or precariously housed individuals requiring transitional care, such as those with addictions, mental health, intellectual disabilities. They would otherwise not be able to achieve or maintain housing. The Wellness and Recovery Center will be OHIP insured and will house WMS, RAM, several outpatient health programs like ACT, and is the first of its kind in Canada. So we're looking forward to these new centers for sure.
And that ends our formal part of the presentation.
So Heather, there's a question here for clarification and some education for those on. So the question is, how does the CPs administer both Suboxone and or buprenorphine naloxone and buprenorphine XR or Sublocade name brand?
How do they administer? Well, we do carry a supply. We keep a lockbox in our bag. of controlled substances. This isn't new to community paramedics who have been using symptom relief in palliative care for a long duration. Timmins also has an amazing program where they're able to provide Suboxone by medical directive for folks who have had an overdose reversed and are interested in starting OAT. We really hope to see this program come our way in the new year. We do careful training with our students, with our paramedics, pretty much anyone who's interested, pharmacists in our area, because we are such a huge geography and there's very few places to access addictions medicine, to train how to administer buprenorphine extended release appropriately. And we delegate that.
And you have a medical directive as well for the CPs for specific things when you're not on site?
That's right. So typically, because it's just me currently, we aren't big enough to have that. It's a delegation. It's a call. It's a consult, and I provide that verbal order.
And then can you just speak about the relationship with the pharmacy that we have to access some of this stuff?
Yeah, we're very fortunate within our, I suppose it's fortunate. So within our region, we have 2 pharmacies, 3, I guess, technically, just outside the border of Grey County, where we can access buprenorphine XR.
Just to let everyone know, I've now allowed the attendees to unmute themselves. So if you'd like to ask a question, go ahead and raise your hand. And then just wait until you're called on and hold to talk as you ask your question.
Christine.
Oh, Christine. Okay. Thank you. That was an awesome presentation. So coming back to the Sublocade, so when you say to be able to access the Suboxone XR, would you be prescribing it? The prescription goes to the pharmacy, you have to pick it up. So like, who's actually paying for the injections? It sounds like a lot of your folks don't have ID, which means they wouldn't have an OHIP card.
That's right. So a lot of individuals are known to previous pharmacies, which is really helpful. And we have very positive relationships with our hospital pharmacy, who is generally able to front us one. And then we work very hard and have great relationships with social services to get that emergency drug card with OW. So typically within the same day, we've figured out our finance aspect of things. We do stock some in our own fridge. Here we have ready. There's individuals who stay with us for 7, 8, 9 months who are still not ready and not able to attend a primary care or a RAM visit on a schedule to receive their medication as we would expect somebody with fewer inequities might be able to do. So we travel to them on a schedule when they're able and when they're ready in the setting that is most comfortable to them. So it's not uncommon for us to drive to one of those 3 regional pharmacies to access their Sublocade to give them their shot. Does that answer that question appropriately, Teresa?
Yes, you would literally like go. So you're able to, first of all, you're able to get emergency Ontario drug benefit coverage within a day. That's incredible. And then if someone is living in the rough, let's say, and they're on Sublocade, you would actually be able to give them the injection in their own setting, is what you're saying?
Absolutely. Yep. So we now frequently are macrodosing individuals who, what we say, would fallen off their schedule, perhaps did have an appointment at RAM, but didn't have the means to get there, didn't have the ability to follow through. They will let us know if someone has missed, and we often have ways of finding individuals and asking them if they want to continue their treatment. They often do. It's not a matter of not wanting to be on OAT. It's about those barriers getting into the clinic.
And you guys are primarily funded just by donations and stuff, and from the county?
Yeah, so the county is the fund holder of money now coming from both the County of Grey and Ontario West. The basic needs, supplies, and wound care, all that kind of stuff does come from donations. But as far as medication, like being able to carry buprenorphine, sublingual with us, that again is covered by either Grey County or the hospital.
And is why we talk about in the presentation, and Teresa and Heather can explain why that partnership has just worked amazingly for Grey County within the hospital and within the public sector, and everybody coming together, recognizing that this is an us problem. This is a difficult situation for our counties, and that we as a county, as a family, as individuals that live within the region, we have to do something. So that no door, wrong door approach has really worked well for this program. And I think Heather and Teresa's, they will go literally trekking through the forest to an encampment that is up a hill and over a mountain and beyond a cliff to get to one person, because that's one person that they can save a life for. So I can't give enough credit for the hard work that these women and sometimes men on the team are doing, and it's working. That going to that individual and getting rid of silos is the key for this program.
You're describing as being like a Bruce County problem, but what you're describing, we see it all over Ontario as well. It's too bad that you guys are not able to access a 7-day-a-week funding when it's so obvious you're able to prove the impact you're having.
I believe it's going to come. We're still sort of in our infancy. This is the first time we've gotten base funding now for the Grey County aspect of our funding, so for the human resources piece. But we do anticipate that Ontario Health West is listening and seeing our outcomes. We're keeping people out of emerge. People are not dying. All those important aspects of care are improving. So we do have high hopes that will be a 7-day expanded program, and hopefully we'll create this hub and spoke and be able to support counties like Bruce and other regional programs that need something similar, especially in the rural aspects of Ontario.
Anyways, hats off to you guys. This is pretty incredible.
Katie Denham.
Hi, team. Thank you so much for the talk. I thought it was amazing. I'm curious. I put a couple questions in the chat, but I have a different one. I'm curious about I'm going to call it, for better or worse, the fad, the mobile vans that a lot of substance-related teams have been using. Did your team consider a mobile van? Did you ever have one? Why or why not? Why is this more, it looks like legs-based approach? Why is this working for you instead of that?
Do you want me to take that?
Sure.
We have a mobile ambulance, which I think is way cooler to start with. We are completely public. There is no private funding going on here. There is no OHIP billing. As NPs, everything we do is there's no fee-for-service activities happening. And our collaborations are working. The community paramedicine program really built a foundation of traveling to the people and working together with our community paramedics to expand that reach. We talk now about expansion to frail elderly. We talk about expanding to palliative, off-reserve Indigenous people. There's so many different ways this model can be applied in a public system. Does that answer your question? We're certainly not opposed to working with the private vans that we have seen. We need more care everywhere, but this model is really working well for us.
Katie. Sorry. Yes, that's super helpful. Thank you. Sorry, I was swallowing. I think that's great. Is it because you're going to the people directly? Do you think it would be as effective if you did have different hubs in a mobile van or something like that, where people had to come to you, like Robyn had described this adventure of going to find people? Is that the part that works, that's making it successful?
It's not a one-prong approach. So we definitely have these fixed site markets where people know to find us. On Tuesdays, we are always here at this time, and that works for some certain individuals. There are other times where we need to do what we call pop-ups. So based on an outbreak, based on a hotspot of overdoses in a certain town, we would then bring our resources there for a time until it's been resolved. So tons of flexibility. So we do have fixed sites, we do have drop-ins, and we absolutely, I love to hike. We live on the Bruce Trail, and a lot of our individuals tend to find safety within the bush. So that is quite effective. It works out for everybody. But we don't have a safe place to house individuals. So giving tents out and having to find people through the bush is not ideal. That identifies a systemic problem of its own. We don't have a shelter. There isn't one place to find, like at the rooming house, there was 40 people we could see in half an hour. We don't have that ability anymore.
That's fantastic. Thanks. That's kind of what I was curious about the locations that you might have, which segues into my other question was about follow-up. How are you arranging follow-up? Is it kind of a quote unquote referral to one of a RAM clinic or substance-based clinic afterwards, or is it still street-based care? How does that work?
Do you want to take that, Teresa?
Sure. So our goal is short-term episodic care. But that is so variable. We have some folks that we've been working with for a year or more, and then other folks that we get them stabilized, they start getting their life where they want it, more back on track, you could say, and they feel comfortable enough reaching out to their previous healthcare provider or that referral onto RAM. So it really is just based on the client's needs, how they're feeling. If we think there's any chance they're going to fall off because we're trying to, reintegrate them to another service, then we wouldn't do that to them. We work with them and listen to what they're saying and how they're feeling, but give them the confidence to move on when they're ready. And they know they can always come back to us. They call our phone directly. So there's no middleman, there's no barrier there. If they go on to a different service and they're like, you know what, I can't do this, it won't work for me, then we'll bring them back, do some more counseling if that's what they need, and get them back on track.
And there's a strong collaboration between all of SOS and RAM and in hospital. So if I go and see somebody in hospital for consultation, get them started, but they have no fixed address and they are going back to encampment or the shelter, I'll connect with Teresa or Heather. The same thing with Teresa or Heather if there's somebody going to emerge and probably being admitted to maybe psychiatry, or they need a WMS bed and they're, of need urgently. There's a lot of collaboration within our teams to try and make sure that there is no door approach. Same thing if somebody doesn't show up for a RAM appointment, we'll reach out to the SOS team saying, hey, this person that was supposed to come didn't come, just a heads up. I've got their Sublocade or name brand, or I've got whatever. And the same thing for Heather and Teresa, this person didn't show up. Do you have time in your clinic for them to drop in and get X, Y, and Z? So it's a good back and forth. And I think that's really important, is that, it's that collaboration within the team for the client.
I'd like to add that it's also, I guess, also an ethical one. So we have a shared by names list consent. So if anyone's familiar with the by names list, which is a housing list for individuals who are precariously housed or unsheltered, this consent form has all of our agencies on it. So once it's been signed by an individual and they understand that all of our agencies work together to partner in services, we then are able to communicate with each other. So then it allows us to speak to many other agencies. Like I say, that's how we are able to get OW started so quickly for individuals. We can speak with them and on their behalf. As well as primary care, CMHA, public health, hospital-based, and all the Grey County programs, housing social services are included there. It's been a huge help in getting consent and being able to speak with individuals.
There is a question in the chat of, do you ever feel unsafe with some of these patient/client visits to tent encampments? And how do you mitigate that risk to your own safety?
Did Kevin ask that question? I'm joking. Teresa, do you want to answer that one?
Yeah, I can answer that one. So because we have the radio system with the ambulance, as long as I'm not terribly far away from the truck, I still have radio connection. And we actually have an emergency button on our radio that gets police there very, very quickly if there was ever something to go wrong. We also have a safe word. So we came up with this because there was a situation where somebody was like, I don't feel great about this, and kind of looking for the exit. So we came up with a safe word amongst our team. And if that phrase is said, we know that somebody doesn't feel right and that we need to go. I've never had to use a safe word, but it's there if we need it. And we also have a new device. It's called Zolio, and it's another emergency device that we wear, and it alerts our managers that we need help, and it locates exactly where we are. So we have, I guess, 3 fail safes there. So I don't think that I've ever felt unsafe. I mean, we trust our own senses and we trust each other to be having each other's backs, and it's never been an issue for me personally.
Yeah, I think.
So, sorry, one more thing about that, actually. We don't go like willy-nilly, like hiking in the bush, like see what we can see today. People have said to us, this is where we are, come on out and see us, whatever. Or we stumble upon a campsite and we'll leave our card and maybe a great big couple liter bottle of water that we've got with us and some other harm reduction supplies. And then they can reach out to us if they want more from our team.
One of the other questions here is around the virtual connection with the NP. So can you guys just talk about when Heather is not on site, how do you connect with that medical lead?
Yeah, we've got a couple of options. And again, the trucks have Wi-Fi, which is fantastic. So in most parts of Grey County, we have internet connection. We all carry an iPhone with us for a formal connection, either by phone or virtual, telemedicine style. And that's how we would do consult with somebody who is brand new to our program or in follow-up.
And the work that you guys do, the work that we all do in mental health and addiction, there's a lot of burnout. Can you guys talk about what has been put in place to help you when you are dealing with the most underserviced and vulnerable population, and how you guys keep yourselves safe?
We've instituted a daily debrief with the team. Sometimes we are not together. We can sometimes separate into partners or threes. So we don't always know what the others have been exposed to. It's not uncommon for our team to come across an overdose, for example, and some of our clinicians are not health sector individuals, so that can be very difficult to sit with. I think respectively, we all have access to occupational supports or private therapy, recognizing that this is a very difficult field to be in. Great communication. We have bad days. We're parents, we're people at the end of the day also, and having each other's backs is really important. We do have formal guidelines and a project charter, which indicates how we move through challenges and disagreements in the plan of care. Rarely is that necessary, but we certainly have that to fall back on when there are challenges. But being in the street is amazing. We have so many partners that also hold us up and we hold them up. So when there is a loss in the community, we know that there's going to be a meaningful memorial, for example, and we have an opportunity to grieve along with our community.
And I just wanted to add to that. I think because we're a small team for our core team itself, and we see each other every day, and we know when somebody's off and something's just not right, and we all have that comfort level to say to each other, like, you all right? What's going on? Do we need to have do we need to talk about something? So there's a level of trust and respect within the team as well. I think that's really important, and that helps us hold each other up too.
Amazing. So Sarah just put in the chat that we are on break. If there are any questions, please let the Medify group know. Heather, Janelle has put in the evaluation, so please fill the evaluation out. That would be great. And thank you guys all. Enjoy the rest of the Medify conference.
Thank you so much for having us.
So just a reminder, we are on break until 10:30. And if you would like, you can visit the break room lounge if you want to chat with any other folks. Thank you to everyone.